Hey, good day and good evening, everyone. It's Tuesday, so it's time for the next IVF webinars. Happy to see you all here. Please let me know in the chat section by typing in the message, of course, if you can hear me loud and clear, and hopefully we will have no technical issues today. So if you can let me know if everything is working fine, I will appreciate this information and this feedback from you. Yes, everything is working fine. Thank you, Lisa, for your feedback. I'm Sophie, and I'm your host today, and welcome to IVF webinars by Egg Donation Friends. We are here week by week, and you can hear week by week best fertility experts from all over the world who are sharing their knowledge with you. All our IVF webinars are recorded, and you can find it in one place at our website at eggdonationfriends.com/IVF-webinars. IVF webinars are brought to you with help of our partners, and our partners are National Fertility Society, fertility clinics abroad, and Donor Conception Network. And today, this evening, we are here together with Dr. Stavros Natsis, UK-trained specialist in gynecological oncology and fertility preservation, who is currently head fertility specialist at Gennima IVF. So, our good evening today goes to Greece. Good evening, Dr. Stavros.
Hello, a very good evening from Greece as well.
Yes.
Nice to hear you, Sophie.
Yeah, happy to have you here, Dr. Stavros. And many of you can know Dr. Stavros probably from his previous IVF webinars, where he answered the question, will the baby look like me? And Dr. Stavros explained phenotype matching and genetic inheritance. So this was very interesting webinar as well.
Thank you.
And today we have a very interesting topic as well. We will talk about most challenging cases with a happy ending. So yes, not to waste any more time, we will start the presentation, which will take around 25 minutes. And I will only tell you that after the presentation, we will of course follow with the Q&A session. So if you have any questions, you can type your questions in the chat section. You don't have to wait until we finish the presentation. And after the presentation, we will answer your questions. Okay, so Dr. Stavros, if you are ready, we can start.
Yes. Thank you very much, Sophie, for the introduction. It's always a pleasure to speak to your webinars. Tonight we will speak about a topic that you will see that it will bring some smiles in your faces, and it's some of the most challenging cases that we have come across in our IVF clinic. And what we want to say is that you should never lose your hope and your focus to your aim, and there is always some light at the end of the tunnel. So the first case that we will talk about is a very young couple that came to us from a previous clinic. This couple was 39 years old, and she had multiple IVF failures. She had 8 years of attempts, which resulted in 5 miscarriages, all of them with natural conception. Usually they would hear the heartbeat and up to the 6th week, and when they had the next ultrasound scan, the heartbeat would stop. We all know how devastating this is for a couple. The couple sent some karyotypes to make sure whether it was some problem with the chromosomes, but actually the karyotype of all the embryos that they had sent was completely normal. And she had some investigations done in the previous clinics that she were, and they found since 2013 that this patient had a condition called bicornuate uterus. Here in the diagram on the right hand side, you can see that bicornuate uterus is the presence of a septum, which starts from the fundus of the uterus, And usually it's a hard tissue like cartilage, and it can either be a complete bicornuate uterus by reaching up to the cervix, or a partial, which is the most common. In our case, this lady had a complete bicornuate uterus. And although she had 3 attempts of hysteroscopy in 2015, 16, and 2018 to dissect it, these were not successful, and this was one of the reasons why the embryos would not implant, because there was not a healthy area to do the placentation. We also noticed from the medical history that the patient had a low anti-Müllerian hormone, but thank God she had a low follicular stimulating hormone as well, which gave us some time to let the patient try on their own. We also performed some screening for thrombophilia, which is quite common here in Greece, and we found that she had actually some factors that could cause clots and some difficulty to the baby growth. She also had a test done for natural killers that you probably, a lot of you have heard, but this was done in the peripheral blood, which is not actually very helpful, as the latest guidelines from the European Society of Human Reproduction suggest. And also the partner had normal parameters for the semen. When we saw the patient in our clinic, we of course reviewed all the previous surgical history that she had, and we felt that she should have a hysteroscopy again in order to make sure that this septum will go away. We also told to the patient that possibly she would need a second procedure, because usually these big septums is not easy to dissect them immediately. And after we did the dissection of the septum, we would let the patient try for another 6 months, but not more than that, due to the low AMH levels. So on March 2018, we did the first hysteroscopy, where we used a special tool which is called resectoscope, and we dissected approximately 70% of this septum. And later, on August 2018, we performed a second hysteroscopy, where we dissected the remaining septum. On that hysteroscopy, we also performed a biopsy of the lining of the womb, and we sent it in a lab that we collaborate with in France, because we wanted to see the immune system of the endometrium and make sure that we have a very good picture of what's going on when a baby goes in there, so we know what sort of medication to give to support the pregnancy. In this video that it will start in almost now, you can see actual footage of the second hysteroscopy. So you will see that the scissors goes on the left cavity of the uterus. The uterus is divided in 2 cavities, on the right and the left, and in the center we have this area here, which is actually the septum, which we cut it out, and you can see in the end how large the uterine cavity looks. This is a small example of what a septum is and why it causes abnormal placentation, because it's a tissue that has a very low blood supply. So following the second hysteroscopy, the patient had a natural conception almost 3 months later. And of course, we had to do a very close monitoring of this pregnancy. we advised also for the couple to perform a cervical cerclage on the 14th week of the pregnancy because she had multiple surgeries performed and we were afraid that maybe the cervix would be incompetent. And after that, she had a very uneventful pregnancy and she delivered a baby girl, which was something that made us all very happy. And this is the actual letter that she sent to our clinic to thank for all the support that we gave. The second case that we will speak about is another couple that came to us that had multiple IVF failures and recurrent miscarriages with very low ovarian reserve. When they first came in our clinic, the couple was at the age of 41 with 3.5 years of attempts. We knew that the anti-Müllerian hormone was very low, approximately 0.3 nanograms, and she had performed 3 times IVF short protocols. She had done some modified natural cycles with Clomid, and some natural cycles with no medication at all. All this, they had resulted in one miscarriage on the 8th week, where they tested the karyotype of the baby and it was completely normal, and also she had 3 biochemical pregnancies. From the rest of the screening that the patient had, we noticed that she had a condition called von Willebrand disease, which is actually a condition that impairs the blood clot and the patient is at increased risk of bleeding. She had performed this test that we mentioned earlier, the natural killers of the peripheral blood, which came back as normal. And she had a negative screening for another syndrome called antiphospholipid syndrome, which causes miscarriages. She also had performed elsewhere some diagnostic hysteroscopies twice with no significant pathology as it was reported to us, and the partner had a normal sperm. When we saw the patient in our clinic, we reviewed all the medical notes and we found that, in our opinion, the fundus of the uterus had a mild septum, and this could cause some difficulty in the implantation of the babies. The plan that we told the patient would be to repeat the hysteroscopy and create some implantation cuts, which is actually a technique that we do quite often to help the implantation of the baby, and then immediately perform an IVF treatment because the age was 41 and the anti-Müllerian hormone was very low, so we didn't have a lot of time to wait for a natural conception. We also discussed with the patient the possibility to perform a biopsy of the lining of the womb to determine the immune profile and find the right treatment post-implantation. So on January 2019, we did the hysteroscopy and we dissected this small septum that we noticed the patient had, and we created some implantation cuts. We also performed that biopsy that we sent in this lab that we collaborate in France, and it showed that the patient had abnormal cytokines, which actually are some elements that they help the baby do its implantation. And also we found that the patient had increased uterine natural killers. And if you remember, when she did the peripheral blood test, they showed that it was actually normal. So this is something that proves that this test that a lot of couples do, they don't really have a great clinical significance. So according to the results of this biopsy, we knew what modifications we should do to the treatment that the patient had after the implantation of the embryos. 3 months later, we did a modified natural cycle stimulation, and we used a medication called Clomid, which actually helps the patient a lot, especially if they have a low ovarian reserve. We collected 2 eggs, and only and 2 out of 2 fertilized, and we transferred one good embryo on day 3, which actually went well, and we had a positive pregnancy test. Again, we performed the cervical cerclage on the 14th week of the pregnancy, and we had a very close monitoring of the pregnancy. It's very important to tell you that this patient could not believe that she was pregnant, and she needed a lot of psychological support because she felt that she could do something that could stop the pregnancy. So we had to be very, very close and ask for psychology review as well. All went very well, and she delivered a healthy baby boy at 39 weeks of pregnancy, which again made us extremely happy. The next case that we will discuss is something that it's very it's strange, because it's a couple that had approximately 30 IVF attempts. It's the largest number that we have heard in our clinic. When they saw us in our clinic, she was only 37 years old, and she started the attempts really early. Unfortunately, 8 years of attempts and 6 IVF cycles and 25 natural cycles later, she hadn't succeeded anything. She only had 1 miscarriage on the 9th week of the pregnancy and 2 biochemical pregnancies. When we saw her in the clinic and we reviewed the medical notes, we found that this patient has had twice surgery for possible endometriosis, which was laparoscopic surgery, and she had twice hysteroscopy for removal of a polyps and also to remove some endometrial adhesions. She would also have a low ovarian reserve, and that was the reason why she had all these natural cycles. And from the rest of the screening, there was no significant findings. The sperm of the partner was very low, and this was another issue that we had to help with our lab. When we reviewed the hysteroscopy, we found that there was a small septum, again, because this was something that the previous clinics, the previous doctors felt that it wasn't a problem, but in our clinic we take it very seriously. And we had, of course, a discussion for egg donation, because after 30 or more attempts, you feel that this patient probably has a very serious problem with the quality of the eggs. After the long discussion, the patient opted to do a final last attempt, and if this was not successful, then we would have to proceed with the donation. And of course, we discuss a lot with our patients, and we agreed with this plan. On 2014 November, we performed a hysteroscopy where we divided the septum, and a few months later, we did a very mild stimulation with a short protocol where we collected 3 eggs. 2 out of 3 got fertilized, and 2 good quality embryos were transferred on day 3. The patient became pregnant, and she actually delivered the baby boy. Again, she needed a lot of psychological support during the pregnancy. And this was one of the thank you letters that she sent to us. And of course, it's in Greek, so probably it's not easy to understand it. Moving on to the 4th case that we're going to discuss. This is a completely different case. It shows that women that they have multiple medical conditions, and many women can have this. They can become pregnant if you get the right treatment. And this lady, when she visited our clinic, she was only 44 years old, with 7 years of attempts. And she had in her history 1 natural conception, with the pregnancy that had to be terminated because the the child unfortunately had a genetic syndrome which was picked up in the nuchal translucency. The body mass index when we saw her was 37. She would suffer from hypertension. She was under medication for that. She had diabetes, and again, she had medication for that. And she would suffer also from 2 strokes, and she was under a neurology review. All the previous clinics that she had seen, they had actually told her that she couldn't become pregnant, and probably she would have to look to the option for other options like adoption, and that was something that the couple was not ready to do. She had done some attempts with some mild stimulations and some IVF attempts as well, but this had not succeeded. And she had the hysteroscopy with the removal of the polyps a couple of years ago. The important thing is that her partner had a serious problem as well. She would suffer from obstructive azoospermia, which is actually a condition that causes difficulty in releasing the sperm. And to get sperm, you have to do a testicular biopsy, and this is a quite difficult procedure to perform for a man. Anyway, the patient had done that, and he had some frozen sample which he brought in our clinic. After we reviewed the DVD of the previous hysteroscopy that the patient had, we found that there was a small septum in the uterus, and our plan was to make sure that the lining of the womb would be excellent in order to accept the embryos. Of course, we asked the patient to go through a more healthy way of life, and she adopted a much healthier way of eating and losing weight. She had a review from a cardiology, a review from endocrinologist and neurologist to make sure that she would go through the pregnancy without problems. And of course, she decided to go ahead with egg donation, which has actually excellent rate. It's 80% the success rate that it is reported in our clinic. We performed the hysteroscopy in March, and then in September we found the ideal donor. It took about 6 months until we found a donor that would phenotypically match the patient. But the first cycle, unfortunately, we had to cancel because the donor did not meet the expectations in terms of the number of the eggs that we collected. So next month we did another cycle that produced a good amount of eggs, approximately 9 eggs. 4 of them got fertilized with a frozen sample that the partner had, and 2 good quality blastocysts were transferred. We used one of the latest technology that we have in our lab, which is an incubator, which we call embryoscope. This incubator can give us some more information about the development of the embryos, and this is a way to do a non-invasive prenatal screening that help us pick the 2 embryos that have the best chances of success. We transferred the babies back. She had a positive pregnancy test, and after a very, very close monitoring, she had a completely uncomplicated pregnancy, and she delivered a baby girl with a cesarean section. And actually, she felt that it was so easy that now she's considering to do a second baby with us. The last case that we will discuss is a case with a very severe male infertility, which is also a very big problem for couples, and usually the options that they give is to go ahead with donors. So the girl was only 27 and the partner was 50 years old. he would suffer from azoospermia, which, as I said earlier, is a condition that the partner does not produce any spermatozoa in his semen, and he had multiple sperm analyses that wouldn't identify any healthy spermatozoa. So the rest of the clinics, they had given him instructions to either do a biopsy immediately or go ahead for a sperm donor. When we reviewed the couple in our clinic, we discussed about the plan and what they wanted, and they felt that they should do some series of sperm analysis. And if we could identify some spermatozoa moving, then we would use them and we would cryopreserve them until the attempt. If no sperm was identified, then we would have to do a testicular biopsy. But that would be our last option. So on February, the partner came, he did the first analysis, and actually we found 5 healthy spermatozoa moving, and the specimen was cryopreserved. And a month later, he did the second sperm where we identified eight healthy spermatozoa, I'm sorry. Again, the specimen was cryopreserved, but we have to tell you that our embryologist had to stay up to 12 hours to find moving spermatozoa. And this is something that is very impressive because they took the extra step and they made sure that this patient would avoid having a biopsy, which is painful for many men. So after we secured that we had the sperm, we proceeded with a short protocol for the wife. We collected 7 eggs, and 1 out of these was fertilized. And one good healthy embryo was produced and transferred on day 3. She became pregnant with the first attempt, and she had an uncomplicated pregnancy where she delivered a baby boy of 3 kilos. So reaching to the end of the presentation, we would just like to address to all the couples that they are now in the middle of IVF treatments, and especially if they have multiple failures, that they shouldn't lose their hope and their focus, but it's time to take a deep breath, reassess things, and maybe trust their next attempt to a clinic that they will use a different perspective, and maybe they will look at their case with fresh eyes. We believe that the clinics that they do that, usually they have a multidisciplinary approach where many fertility experts meet, exchange opinions, and also it's not only the doctors but also the embryologist, psychologist, midwives, so we can come up with a tailor-made plan that would be maybe the best chance to work for each couple. We also strongly believe that the clinics should use the latest advances of technology and the latest medical advances after careful review, like the embryoscope, for example, which has helped a lot and has increased the rates of success because it's a non-invasive way to do some pre-implantation testing. The biopsy that I mentioned that we sent to France to determine the immune profile of the uterus. And of course, we strongly believe in the fertility education of the couple, try to make them understand what we're going to do into their bodies and get a consent. We believe more in a fruitful cooperation rather than a strict relationship, a doctor-patient relationship. We feel that patients should be taking decisions with us and not just following our instructions without any objections. So closing, I would like to tell you that a quote that we usually use in our clinic, that it seems impossible at some point, but until it's done. This was actually said by Nelson Mandela, but it's something that we quite often tell to our couples in our first consultation. Thank you very much, and I would be very happy to answer to your questions. Thank you.
Huge thank you, Dr. Stavros, for your presentation. We will now take questions from our attendees, which we have many now on the lists. So we will start with the first
Yes, of course. So, thank you.
In patient number 2, how was the medication modified based on the results showing elevated NK cells?
Excellent question, Rebecca. Thank you very much. So actually, this new biopsy that we perform, it gives us an idea of what is the immune profile of the uterus? Does it have lower activation when a baby goes inside, or does it have over activation when a baby goes inside? The uterine natural killers actually, when their level is higher than the desired, they can become quite aggressive towards the embryo. In that case, usually patients, they will have to take steroids, possibly 20 milligrams of cortisone up to the 12th week of pregnancy. But there is a group of patients that they have to do another form of immunosuppression called intralipids. It's an IV medication. We give it usually a few days prior the embryo transfer, and it can help with the immunosuppression locally in the uterus. And this medication needs to be repeated on the first week after the implantation, after the embryo transfer, and 2 weeks later. There was a very good study that was done in France, where they tested approximately 400 women that they had multiple IVF failures and miscarriages, and they found out that almost 340 of those women, they had problem with the immune profile of the uterus. It's something that we strongly believe, because not every patient that has a miscarriage has the same reason. Every patient is different, and I believe it's something that other clinics could also consider doing as well. Thank you.
Perfect. Thank you for your very detailed answer to this question, and we will not waste any more time and take the next one. This one. After multiple miscarriages at approximately 8 to 10 weeks, would you suspect immune issues as a cause for miscarriage?
That's yes, that's a very good question, Dan. Definitely, we would suspect immune issues, because of course, it would be better if I had a little more information regarding the age and also the previous surgical history. But just to know, 70% of miscarriages are caused by an embryo that doesn't have the right chromosomes. This is 70% of the reason. 25% of the reason of a miscarriage usually is the receptivity of the uterus, and this is something that we actually can intervene. 5% is thrombophilia and other more rare conditions. So if you had a multiple miscarriages, 8 to 10 weeks, I don't believe that all of those had to do with karyotype issues of the embryos, and definitely they should look more into the receptivity of the uterus. I agree with you, Dan, and there are many tests that you could perform, and if it's quite detailed, the answer, but if you need any more, we would be happy to answer in an email or something. Thank you.
Yes, indeed. Thank you for the question and for all the data you gave us, Dr. Stavros. And if you contact, even throwing us an email, we will forward everything to Gennima IVF.
Of course, we would be very happy to help. Yes.
Thank you. And we will now take a look at the next question, which is about egg donors. What kind of criteria are you looking for from an egg donor?
Okay, that's very good. So usually when we go ahead for egg donation, Diana, we the first aim is to make a very good phenotypic matching for the patient. When we mean phenotypic, the donor and the recipient need to have a lot of similar characteristics like the hair color, the smile, the eyes, height, body mass index. We try actually to find almost an identical twin. After we find a person that looks like the recipient, we have to do a lot of screening to make sure that the donor has does not have any problem with chromosomes and doesn't have any genetic conditions like cystic fibrosis or thalassemias, etc. We also do screening for sexual transmitted diseases like hepatitis, syphilis, AIDS, and also we take a very thorough medical history to make sure that they don't have any genetic conditions and any history of psychiatric disorders. Once we tick all these boxes, we feel that we have found a good donor. Of course, she needs to be young, up to the age of 30, 35 the most, because even young girls, if you collect 10 eggs, possibly 2 or 3 they will be healthy and they will have normal chromosomes to give a healthy pregnancy. Even a 22-year-old girl, 1 egg out of 4 is healthy. So we try to find young girls and collect as many eggs as we can. So these are some of our criteria. Thank you.
And thank you for explaining this to us. Of course, we have the next question. No surprise.
Yeah.
And this will be this one. How long must you wait after a cesarean section before trying for a second child?
Well, we believe that the minimum should be 9 months. The uterus needs to heal, and because of the scar tissue, when you do a C-section, there is some scar tissue formation, and our biggest worry is that if a woman becomes pregnant earlier, as the uterus distends, the scar tissue will open, and usually it's 9 months, the smallest time interval that we would suggest for someone to go ahead for another pregnancy. Thank you.
Perfect. Thank you for the question and your answer, of course, as well. And the next one on the list and the next one to be published will be this one. Is there anything one can do about improving sperm motility, etc.?
Thanks, Bridget, for the question. Yes, this is a very good question. Here, the last few months, there is a lot of discussion about a new test called oxidative stress of the sperm. It's actually a sperm analysis that can measure the free radicals of oxygen that live in the male sperm. If these free radicals are above a certain level, they can become poisonous and actually destroy the genetic material that its sperm is carrying. So in our clinic, we do that quite a lot, and if we find that this is elevated, we give usually a combination of vitamins that they are antioxidative vitamins like vitamin E, for example, or zinc or um, other sort of vitamins. And this can play a crucial role in the improvement of the sperm. But we have to say that taking vitamins without knowing if you have elevated oxidative stress can make the opposite effect. If someone has a normal oxidative stress and take vitamins, this can cause some problem in the sperm and can make it actually worse. So we would advise you to do a more detailed sperm analysis, and if this shows signs that there is increased elevated oxidative stress, then yes, you can take some vitamins. If not, in that case, we wouldn't recommend that. Thank you very much.
Yes, thank you for the question and your answer, of course.
Yeah.
Now we will take a question which is in two parts.
Yeah.
I want to have IVF treatment, but I must have a baby letter from a baby doctor in the UK. Can there be any clinic abroad that could do the test and scan together before treatment? Does your clinic do this for me at 53 years old before December? And how much does this cost in your clinic?
Thank you, April. Usually, in the European law says that we cannot perform any IVF treatment here in Greece if a woman is above the age of 50. And this is a European regulation, and of course, it's very strict. There are some areas that they could help you. Maybe we know for a few clinics in maybe Russia or in northern Cyprus that maybe they could help you, but unfortunately not in our clinic because we have to follow the strict European rules. There is some discussion here in Greece to increase uh, the limit up to 52 or 53 years, but still this is on discussion. So unfortunately, we wouldn't be able to help you, April. Maybe you could uh, address that to these clinics. You could do some research in the internet for the clinics in Russia, possibly. Thank you very much.
Yes, of course. Thank you for letting us know about this as
Yeah.
well. And we will now jump to the next question, which is this one. Does Viagra help in growing the endometrium line after the start of progesterone?
Thank you, Anna. Viagra, yes, it can actually help because it can stimulate locally the blood supply, and definitely when you go ahead to transfer thawed embryos in women that you see that their lining is not developing, it's not growing well, then you add some Viagra. But I have to tell you that after you start the progesterone, there is very little effect of the Viagra. Usually you give it before you start the progesterone. Once you start the progesterone, it's quite difficult. Usually progesterone starts once the lining of the womb has reached the level of 8 to 9 millimeters. So the answer is yes, it helps, but not after you start the progesterone. We would give it prior the progesterone. Thank you.
Thank you for this one as well. Of course, we have another one. What is the cutoff age for egg donation patients?
It is one day, you can do the embryo transfer one day before the patient becomes 50 years old. So In Greece, it's 50 years, and I think other parts of Europe is 45, but in Greece is 50. Outside the European Union, there are clinics that they can accept patients that they are 52, 53, but this in Europe, the cutoff is 50 years old. Thank you, Mercy.
Yes, and thank you for the question and your answer. We will now take the next question.
Yeah.
We transferred two 5AA embryos on 11 out of 14, but our HCG seems at lower end around 90. 11 DPT, 5 DT. Any suggestions you have for a successful pregnancy going forward?
So, Diana, I'm hoping that your beta HCG will rise. Well, it's I don't know whether the embryos you transfer were thawed embryos or they were fresh cycle embryos, because usually sometimes in the thawed embryos the beta HCG starts lower, and this is something that it's common, and I'm sure it will pick up later. Or if you had a pre-genetic screening and they took some cells from the embryos, because again the beta HCG starts very low, so I don't have the full information, but if we assume that it's a normal cycle and you just transfer to embryos with low beta HCG, unfortunately there are not now many things to do apart from adding some progesterone to help with the implantation. And if this doesn't go well, in that case, there are a few blood tests that you can perform to check the immune activation of your body, to check thrombophilias, to check also if you have a condition called antiphospholipid syndrome. Sometimes you can treat those with some blood thinner injections or some aspirin, but after you have confirmation that this medication would be helpful. So we'll keep our fingers crossed. Maybe your beta HCG will pick up later, which is something that we have seen quite often. So don't lose your hope. Thank you.
Yes, and thank you for the answer and all the support you are giving us, Dr. Stavros, so as well for the answer. We will take a look on the next question. What do you think would be the success rate of an euploid 5 days blastocyst 4BB? Would it be the same if the euploid blastocyst 5AB would be day 6?
Thank you, Anna. So the first thing that I don't really know is the age of the person that produced the blastocyst. The success rate of each embryo, it depends a lot to the age of the woman that produced the embryo. So if we had the blastocyst 4BB and the patient was 32 years old, I would tell you that we have a 40 to 50% chance of success. But if the patient has a blastocyst 4BB and is 42 years old, that success rate drops to 20%. The euploid blastocyst, when is day 6, usually the success rate is lower, because for an embryo to reach the state of the blastocyst, if it takes 6 days instead of 5, it means that the baby is very slow in its development, so we wouldn't give a lot of hope for the day 6 blastocysts. Even if they look good, usually they have some success rate, but not the same as a day 5 blastocyst. So I hope I answered your question, Anna. Thank you.
Yes, of course. Thank you for the question and your answer. The next question will be, we have a lot of questions to go.
Okay, that's good. That's very, I'm
So
happy
that's
for
why
that.
Yeah, I was a little lost for a second, but we have the next one. Thank you so much for a wonderful and informative presentation. I have been trying for 5 years. I have had 2 failed UVs and 1 failed IVF with egg donation in October. So I needed this presentation to give me some more hope, which I did. Thank you, Lisa. It was actually the shout out, which was not a
So thank you
question,
very much, Lisa. You
but
made
I
me
think
smile.
yes,
Yeah.
that after so many questions, we can have the shout out, and it's like high time.
Lisa, definitely my advice is don't stop believing in yourself and don't stop trying. You will succeed, and that this is for sure. The only person that doesn't succeed is the one that he doesn't try. So I'm sure you will succeed. Don't give up your hope. Thank you.
Yes, and fingers crossed, and good luck with all of it from us as well. Now we will come back to the questions.
Mhm.
Is a chemical pregnancy loss that happened to a young lady 22 years old 1 year after she delivered a healthy baby a concern? What is your recommendation, please?
Thank you, Biso, for the question. A biochemical pregnancy, it wouldn't concern me a lot. It's something very, very common, and actually, the majority of the women will have a biochemical pregnancy during their life. It's just they will never find out about it. The guidelines usually recommend that if you have 3 biochemical pregnancies or more, then would be something that you would have to do some additional tests. The fact that the lady is so young, only 22 years old, it wouldn't really concern me. It happens. It's 5% chance, but it can happen. So I don't think you should do anything more about it unless there is a second one. In that case, there are some clinics that they can recommend to do some blood tests, some first screening. The only thing I don't know is you told me that the lady delivered a baby boy. Just I don't know whether it was a normal delivery or a cesarean section. Sometimes C-sections can cause some problems, but I think it's very, very rare, this condition. So I would just wait and see if that happen again. Thank you very much.
Thank you for your advice on this one. The next question will be this one. What are some of the tests to check the receptivity of the endometrium for implantation?
Thank you, John. Yeah, we have so there are multiple tests that now they are available to test the receptivity of the endometrium. In our clinic, we have ways. We perform some blood tests and we try to see whether you have positive some of the antibodies, like the lupus antibody and similar. These show some. It's a condition that could show some autoimmunity, which actually suggests that your body can become a little more aggressive towards your body or an embryo. Apart from that, we have much more detailed tests. The hysteroscope is a very good test because you can actually see the lining of the womb and check whether there is a small septum or a small polyps, something that could impair the placentation. And of course, there are some more difficult tests to perform, like the one that we send in France, where you need to take a biopsy from the lining of the womb on the implantation window and not in any day, just in the implantation window, which is actually only 4 days during your cycle, and send the sample and test the uterine natural killers and uh, some other um, uh, some other elements that they are called cytokines. They help with the implantation and the formation of blood vessels for the embryo. There is the ERA test, which you have probably read about, which helps identify the ideal implantation window where your endometrium is more receptive. So we have quite a lot of tests. I would suggest to start with something mild like blood test to check for autoimmune antibodies and proceed to other tests if you have something positive for that. Thank you.
And thank you for this answer as well.
Thanks.
The next question on the list is this one. My husband has a sperm sample from 2007 from Sydney, Australia, that we want to use with our last 11th IVF attempt. Has sperm freezing changed over the years? I think it was slow frozen. From what I understand, vitrification of sperm is not done, other than in Japan at the moment. Vitrification of eggs and embryos has changed as the norm now.
Thank you, Angela. And yes, actually, since 2007, we have a lot of change in the vitrification of the sperm and the eggs. We use a new technique the last 5 years that they help a lot to freeze the eggs or the sperm quite quickly, so it will not have a lot of losses during the it has a lot of losses during the procedure. The new technique, unfortunately, we used it the last 5 years, so probably in your case it was done in 2007. It plays some role, but there is not a chance to try and use some fresh sperm for your husband. If not, then of course would go with your frozen sperm sample, and I'm sure that you will have some good results. Thank you.
Thank you for the question and for your advice, Dr. Stavros.
Thank you.
Next question, which we will take and ask you for your answer,
Mhm.
will be this one. Who do you advise PGF testing for? All patients?
Thank you, Rebecca. No, we wouldn't. In our clinic, we don't routinely recommend pre-genetic screening testing. For people that they don't know what PGS is, actually, we take some cells from the embryos that we have created in the lab and we test them for chromosomal abnormalities. It's a condition that we would recommend to, it's a procedure that we would recommend to a couple only if they had some issues with their karyotypes. There are many people that they don't know that they have a condition called mosaicism. So let's say there are people that they have 95% of normal cells and 5% of cells that they have, for example, Down syndrome. These sort of couples, they would benefit from pre-genetic screening. Also, other couples that they would benefit from that is couples that they have genetic conditions like cystic fibrosis, and you don't want that to go to your child. In these cases, yes. And there is another case that we would recommend pre-genetic screening is usually for younger couples, let's say 32, 35, that we have transferred many blastocysts and all of those have not resulted in a pregnancy. In this case, we suspect strongly that most of the embryos have genetic abnormalities, and in that case, we would go ahead for pre-genetic screening. You have to bear in mind that it's almost like a surgical procedure to the embryos, and if you have a healthy embryo, you can actually delay its development. So you should be very, very careful which patient you choose to do that. I know that in the United States they do that quite a lot, but this actually is not a practice that we would feel strongly to do in every couple. Thank you.
Thank you a lot for the question and the answer as well. Now we will take a question, which is this one. For male with azoospermia chromosomal microdeletion with no AZFA, AZFB, and AZFC, what are the chances of getting sperm on TESE? All other blood tests are normal.
Thank you, Ranga. Actually, there's quite a lot. We perform a clinical examination and we try to feel the epididymis, which is actually like a reservoir for the sperm. If we can feel that the epididymis is full with sperm, we go ahead and do this procedure. The TESE procedure is putting a needle there and trying to take some um, sperm from this depot. It's like a storage for the sperm. And if this is not successful, then again with a larger needle, we try to take tissue from the testicles, and usually the embryologist will find their sperm. It's highly unlikely to proceed to the normal biopsy that you have to dissect and cut the testes. So usually almost 70 to 80%, we can take specimen with these two needle techniques that we mentioned earlier. Thank you very much.
Yes, and thank you again for your answer to this question. Next question. I have
Hypothyroidism.
yes, which was caused by a row of hyperthyroid for that.
Hyperthyroidism, yes.
Yes, and now
Yeah,
caused problems to my fertility. I had an
understand.
IVF, but couldn't proceed because three oocytes that responded was ovarian cysts. Is there anything you can suggest? Because I really want to use my eggs. I have low ovarian reserve, low AMH, slightly high FSH.
So yeah, thank you very much. Definitely, you shouldn't stop trying. This is the first advice, and you shouldn't be discouraged. Women that they are younger, let's say they're less than 42 years old, usually even if they produce one or two eggs, they have good chances of success. In your case, what we would suggest is maybe start some supplements that they have DEHCA, which is a supplement that can stimulate the ovarian reserve and maybe boost your ovaries and give us some healthier eggs. We would also recommend you to take vitamin D and folic acid. You have to take this approximately 2 months before your next IVF attempt. And definitely what we would recommend is to do an IVF attempt with very mild stimulation, maybe use some Clomid, because giving you high doses of injections usually have the opposite result, and they can result to formation of ovarian cysts. So this would be our advice. Thank you.
Yes, and huge thank you again. And next question. Do you have sperm donors? If so, where are they from?
Thanks, Aid. Actually, we do not have sperm donors in our clinic. We have only egg donors. Here in Greece, there is a very good sperm bank which works under European Union laws and actually does a very, very good job. 90% of the donors, they are Greeks. We know other sperm donor banks like Cryos, which has also excellent reputation. Thank you.
Thank you for this as well. What is the possibility of carrying a pregnancy to term after an intramural myomectomy?
Thanks, Lovely. Yeah, actually, the intramural myomectomy doesn't really affect your the possibility of carrying a pregnancy to term. Of course, again, it depends how big was the fibroid. It depends on the way that it was taken out. Was it with laparoscopy or with an open surgery? Of course, we are a little scared of the scar tissue that is formed when you take out the fibroid. But in general, you can carry on with your pregnancy at least up to 37 to 38 weeks. The majority of the women that they have intramural myomectomies, they deliver with cesarean sections, approximately at 38 weeks of pregnancy. Uh, so I wouldn't really want you to deliver earlier just because you had this sort of surgery. So I think it's quite high, the chance to carry a pregnancy full term. Thank you.
And thank you for your advice on this one. Of course, the next one, what's the ideal duration time to take estrogen and progesterone before an embryo transfer? And thanks.
Thank you, John. So the ideal duration, usually it's approximately 12 days, 12 to 15 days of estrogen. Estrogen is a hormone that helps to build up the lining of the womb. There are some women that they respond quite quickly to that, and on day 8 or 9 of the estrogen, they have developed a lining of 9 millimeters. But there are other women that they respond quite, uh, it's not that quick, the response, and they might develop this lining of the womb on day 15. Sometimes we have given it up to 20 days, the estrogen, until we build up the lining. The progesterone, that depends on the what sort of embryos you have to transfer. So if you have to transfer blastocysts, you have to take 5 days of progesterone. If you have to transfer day one embryos or day two, then you need to start taking progesterone for 2 days. So it depends on the age of the embryo. Thank you very much.
Yes, and thank you for your answer and of course for the question. And the next one which we have
Mhm.
is this one. Hi, we did a spermogram that was normal except teratospermia 2%. Do you think it is necessary to perform the DNA degradation test? My partner is fertile and already has 6 healthy children naturally. We thought about egg donation because my age, AMH 2, yeah, PCB link 1.
To be common. Thank you very much, Nadia. Yes, to be honest, 2% is quite common to see. It depends on the other sperm characteristics. So it's 2% of a sperm that has 100 million of spermatozoa, or is it 2% of a specimen that has 3 million? It's very, very different. The fact that your partner has already 6 healthy children suggests that probably you shouldn't do the DNA degradation test. Only it could only give some additional information to the embryologist and tell them which sort of technique of fertilization to use. Will they use a simple IVF or will they do a microinsemination? But I wouldn't be very stressed about that. It suggests that it has a very good fertilizing capability, your partner's sperm. Uh, the AMH that it's only 2 picomole suggests that it's on the very low side, but it definitely has to do with age. So if you are, let's say, 38, many women have achieved pregnancy with very low AMH. If you are 44 or 45, in that case, yes, it's quite difficult. And if you want to have success, we would advise to go ahead for egg donation, which is 80% the success rate. But I don't know how old you are to tell you exactly the statistics. Thank you very much, Nadia.
Yes, and thank you. And for now, I don't have any follow-up comment on this one. So yes, I will not tell you how old Nadia is, but yeah,
it's fine.
we will continue with the question. You can always throw me an email, which I also put
Yes,
in the
we
chat
will be
section.
very happy
Yeah,
to
and I will
answer.
forward everything to Gennima IVF tomorrow.
It would be a pleasure.
Yeah. So we have a few questions to go, but this will be the next one. Is hysterosalpinography indicated for IVF with oocytes donation?
If you have decided to go ahead with that, we wouldn't really recommend to do that test. That it's quite painful for some women. We only perform this test as a fertility screening to see whether a couple can continue having attempts or if there is a severe blockage in the tubes, and the couple should go ahead to explore other options like IVF. If you have decided to go with oocyte donation, we wouldn't advise you to do this sort of test. It wouldn't add any other information. Thank you.
Yes, and thank you for the question and, of course, for your answer. The next question will be this one. Can DNA fragmentation or FISH test be done on frozen sperm, as apparently nothing was done on my husband's frozen sperm?
Yes, Angela. I think in our clinic we perform that many times. Sometimes the embryologists are stressed that the medium that they have used to do to keep the sperm thawed alter the can alter some of the results, but we feel that a FISH test or DNA fragmentation test could give some additional information because they would dictate the best technique for fertilization. I think in our lab, yes, we would do that. I don't know in your lab whether they would strongly feel about that, but it can be done. Thank you.
And thank you for this one as well. The next one will be this one. What do you think of 49 years old women with adenomyosis on warfarin because of recurrent pulmonary embolism?
Thank you, Mercy. Definitely, it's adenomyosis is something that definitely causes some difficulty in IVF. For the people that they don't know, adenomyosis is a condition that you have thicker walls of the womb. And there are some papers suggesting that due to the adenomyosis, there is some difficulty in the implantation because of some biochemical changes in the lining of the womb. Usually, doing a good hysteroscopy and creating implantation cuts can help a lot with the implantation. And if you decide to go ahead with egg donation because of the age, I think it could be successful. The warfarin that you take for recurrent pulmonary embolism can be changed, definitely, in blood thinner injections that many women do. It's just, I don't really know the reason why you have been having this recurrent pulmonary embolism. I don't know if you have some cardiac arrhythmia or other reason, but I'm sure that your gynecologist could have a consultation with your cardiologist, and I'm sure you could go ahead with that. I don't think it would be something to stop you from being a mother. Thank you.
Thank you a lot for the question and the answer, of course. The next one, and we will be almost done with the question because time is flying, but the next one which we will take will be this one. Diagnosed with severe endometriosis, two laparoscopy removed tubes. This has resulted in multi-rounds IVF with own egg and 3 rounds with egg donation, which resulted in 2 miscarriages.
Oh.
Last cycle, I had biopsy for endometrium lining. Would you recommend any additional test? Age 34 and 2 frozen donor eggs left.
Well, Nicola, you're very, very young, to be honest. We wouldn't go ahead with egg donation unless you are on menopause for some reason. 34-year-old girl, usually every 4 eggs, one is excellent. It has good chromosome and it can lead to a healthy pregnancy. Um, I don't know what the lining of the endometrium showed. I think it would be very important if you would like to send us the result. We would be very happy to review it. I think it was good that you did this sort of test, but I would definitely recommend a hysteroscopy with creating implantation cuts and not just doing endometrial scratching. And also, we would recommend some mild curettage of the lining of the womb to help it regenerate. We have seen much better receptivity following a hysteroscopy. So I would recommend you to do a good hysteroscopy this month and the next month. If you feel ready, you could transfer the frozen eggs, and I'm sure you will be very successful. Of course, it would be great to see what the biopsy showed. Thank you.
Yes, and again, huge thank you for all of you for your question and your answers, Dr. Natsis. So
Yes.
yes, I believe, will take almost the last question, and this will be this one. This will be coming back to the question which was already asked, but we have additional comments. So thank you, Angela, for rephrasing the question. My husband is 54 years old, and I don't want any autism dwarfism from an older guy if we use his current sperm rather than his frozen sperm from 2007. What do you think? A fresh sample from an older man, as there are no tests to be done on sperm for autism and dwarfism, and don't want to waste any good donor eggs.
That's a very yes. I understand your what you're thinking, Angela, and this is something that it has been heard that the age of the father is somehow related with the autism. I have to tell you that there is no study that has confirmed that. In our clinic, what we would do is we would use definitely the sperm that you have in 2007 if the sperm looks good, but we would definitely compare with a frozen sample and see which one has better characteristic. You have to bear in mind that men produce new sperm every 3 months, so I'm not sure that the sperm that your husband produces now could cause autism. Um, it's something that it has not been proven. So we would just um, actually try to see which of the two samples is better in terms of motility, in terms of oxidative stress, in terms of uh, all the numbers, and we would choose the one that looks better to make sure that it will do the fertilization. I wouldn't be worried about autism and all this. Thank you.
Yes, and huge thank you for this one as well. Um, we have a question which is a little less difficult. Can I send a private email to the doctor to give him more information about my case?
Yeah, thank you, Nadia. Of course, I would be very, very happy to review and just give you our advice. It would be great. Thank you.
Yes, and as Dr. Stavros say, yes, I will forward to you Dr. Stavros' email tomorrow, and
Perfect.
you will be all in touch. Okay, someone was writing, and we will take the last question
Of
for
course.
today, and
Yeah.
it will be the final one, and this will be this one. Hi again. some clinics offer a synchronization of the donor cycle with that of the recipient. Other clinics prefer not to synchronize and transfer an embryo already frozen. My question, are the success rates the same with frozen embryos as with fresh embryos?
Thank you, Nadia. Yes, to be honest, we are one of the clinics that we prefer to synchronize the donor cycle with the recipient. That would be our ideal because we wouldn't put the embryo in an additional procedure to cryopreserve it and then do the unfreezing and put it back into the uterus. So if we can avoid an extra step, then we would definitely do that. I have to tell you, though, that the success rates are almost the same. Strong embryos are not affected by the cryopreservation, and this is something that many clinics do, especially if they have patients that they travel from far away, and they want to make sure that they have embryos to transfer, because in some cases the donor doesn't go the stimulation of the donor doesn't go according to the plan, and it would be a tragedy for you to travel 6 hours, for example, to arrive to the clinic and tell you that they don't have an embryo to put back inside. So this is the reason why many clinics prefer first to create embryos and transfer them in a later cycle to avoid having unexpected failures and making you travel in vain. But it generally is about the same, so don't worry about that. Thank you.
Yes, and thank you for your advice again on this question and on Medi, which was asked and answered by you today.
Yeah, it's a pleasure. Yeah, send anything you want. It's fine. We will answer everything.
Yes, and actually, as we have so many questions, now we have so many shout outs. Many thanks for the presentation,
Thanks,
very
Dr.
informative.
Thank you.
Thanks for the great webinar, and
Uh,
thank you very much for all the knowledge you
You're
shared
so
with us.
so sweet. Thank you very very much for everything. It's my pleasure.
We have also a few comments that we will be in touch. And thank you again. I can continue with all those thank yous and thank you very much.
That's
And
amazing.
I will finish with a comment which says such a fantastic, helpful presentation. Thank you. And of course, it was a pleasure that you have so many questions. And of course, thank you for asking those questions and for your trust and for your support, Dr. Stavros.
It's a pleasure to help everybody. I mean, it's if you can have a baby, it would be great for us. It's if we can help, it's a pleasure. Yes.
Yes, and thank you everybody for your time and for being with us. Of course, the recording from today will be available on our website tomorrow, and you will know about all the updates if you follow us on our social media. Of course, I can encourage you to follow Gennima IVF as well. They have great content as well. So please do that. Dr. Stavros, if you want to add anything, if you want
It's
to do a
it,
final comment.
it's always a pleasure, and I just want to tell you that never lose your hope. And honestly, it's much easier than you think. Don't ever lose your hope, and don't let anyone tell you that you cannot succeed in having a baby. Thank you. Have a great night.
Yes, have a great night and day wherever you are, and hope to see you all back here next time. Thank you one more time, and bye bye to Greece. This
Bye.
will be the wrap. Bye.
Bye. Bye. Bye.